Welcome to the Dr. Doug Show, your resource for bone health, hormone optimization, and women's health span through midlife and beyond. So menopause symptoms are something that people talk to me about all the time. Our patients are talking about if they had them, if they didn't have them, how bad they were. I hear lots of complaints and non-complaints, the opposite of symptoms, in the comments on YouTube and on Instagram, etc. What I find really interesting here is that there are women that have some really excruciating symptoms, and they can be absolutely ignored by their providers, even though there is a very clear solution for them. But there are also women that say that they have no symptoms, but then I hear them complaining about things that are actually symptoms of menopause that they just don't know that they're symptoms of menopause. So right now I'm in the middle of writing a book on hormone replacement and testosterone therapy, specifically in women. And in this research, I'm finding this striking contradiction between how we treat men as they age versus how we treat women as they age. And what I want to point out here is that the symptoms of menopause are something that we should really explore. We should have a better understanding of what actually is associated with hormone changes in women. And it's not just estrogen. I'll give you a little surprise there. When we look at aging in men versus aging in women, we treat them so differently. So I want to dig into that. And I want to show you this one study, which I really like, not because it's an amazing study, but because they do a great job of actually showing how the symptoms of menopause in women, other than the ones that you're probably thinking of, and the symptoms of aging in men are nearly identical. And there is one tool that we can potentially use to treat both, depending on what those symptoms are. So stick around. We're going to go through this controversy. This is a super fun topic. I'll see you in a minute.
3, 2, 1.
Here we go.
All right, so let's talk about aging in men first, because I want to set the stage for when I talk about the symptoms of menopause. So when I, again, was doing the research for this book, I had to look at a lot of the research on testosterone for men because, let's face it, there's not as much research on testosterone for women. Some of the research on testosterone for men will show that signs of aging in men are generally going to be treated successfully with testosterone. Really interesting. But let me just run through some of these things. There is a scale called the Aging Male Symptom Scale, the AMS. And the AMS is divided up into a couple of different sections. The first section is psychological symptoms, okay? So these are going to be considered a decreased general well-being, feelings of being unwell or unhappy without a clear cause, increased anxiety, feelings of nervousness or worry that are not necessarily linked to a specific stressor. Also depressed mood, feelings of sadness, hopelessness, loss of interest in activities that they previously enjoyed, and irritability. They can experience mood swings, and they can get frustrated more easily, and they can get angry more easily. So those are all real. And we see that in men, right? We know that we know guys that act like that. And then insomnia, so sleep changes for men as they age, decreased intellectual capacity, all of those things fall under the psychological side. And then there's the somatic or physical symptoms. So these are considered joint and muscular discomfort. So that's, your typical like aches, pains, stiffness, that kind of stuff that gets more frequent. And then increased sweating, kind of sounds like something that women might experience. Exhaustion or increased fatigue, decreased muscle strength, loss of muscle mass. And actually men can feel hot flushes. So again, something like what women would feel. Sometimes they get increased incidences of dizziness, that kind of stuff. And then there's sexual symptoms. Now, when we think of testosterone deficiency in men, most people automatically think, oh, we're going to talk about sexual symptoms, libido and erections. And yeah, those things are in here too. Decreased libido, erectile dysfunction decreases, decrease in frequency of morning erections, and decrease in sexual performance. So those things are in there too. But if you'll notice, those things were actually, there's only 4 of them. And while they might be on the top of most guys' mind, actually there were a lot more of the somatic and the psychological things. So it is more than just sexual function that we're talking about with testosterone. And again, I want to reiterate that testosterone therapy in men that are having evidence of those symptoms, testosterone therapy helps essentially all of them. And so study after study shows that. So we know that for aging in men, we say, hey, we should consider testosterone therapy. Let's look at your levels. And then there's a whole debate on how to treat testosterone replacement in men. And I'm not going to get into that today. Why is that important? Well, it's important because when we look at the recommendations for women, if we look at what the Endocrine Society is saying, what the American College of Obstetricians and Gynecologists is saying, they are saying very clearly to physicians, to providers like myself, that there is no clearly defined what they call androgen deficiency, testosterone deficiency, syndrome in women, and that doctors should not treat women with testosterone unless suffering from HSDD. What the heck is HSDD? HSDD stands for hypoactive sexual desire disorder. So let me actually tell you what ACOG says. That's the American College of Obstetricians and Gynecologists. They say that testosterone therapy is sometimes used to treat hypoactive sexual desire disorder, HSTD, in women, particularly during or after menopause. HSDD is characterized by a persistent or recurrent deficiency or absence of sexual desire or receptivity to sexual activity. Transdermal testosterone has been found to be effective for short-term therapy in treating HSDD. However, the long-term use of testosterone therapy, more than 6 months, for this purpose is not well supported by the evidence, and it's important to note that transdermal testosterone has not been approved by the U.S. Food and Drug Administration for treating HSDD in women. That's true. They go on to say that they emphasize that the treatment of HSDD often involves psychotherapy because they must be crazy. And in some cases, antidepressants because of anxiety is actually what they say. And then the use of testosterone should be carefully considered because antidepressants are fine. But testosterone should be carefully considered, especially since there are potential risks associated with testosterone therapy, such as hirsutism, which is growing hair, acne, virilization, which is growing features like a man, and cardiovascular complications. Additionally, there's a possible association with breast cancer that has been reported. I'm just going to keep going because there's so much to talk about here. Furthermore, it's mentioned that the physiology of testosterone as a normal female hormone is not well understood. And this lack of understanding has led to unregulated and potentially unsafe prescribing practices by healthcare professionals. ACOG advocates for more research and safer regulated products for prescribing testosterone therapy in women. I agree with that last part. It's about the only part that I agree with. So, man, that's really frustrating. So many issues to talk about here. So first of all, when we go back to the symptoms of aging in men, loss of libido, sexual function, desire, all of that in men is clearly associated with testosterone deficiency. We replace the testosterone, those things pretty much get better in most men. Yet in women, if you have those same symptoms, you have hypoactive sexual desire disorder, not a symptom of aging and testosterone deficiency, it's a psychiatric diagnosis. What? Why? Why is it different in women than in men? I have my thoughts, not going to get into that yet. Then when we talk about HSDD and the use of testosterone, they say it responds to testosterone, right? Because it's likely a testosterone deficiency in a lot of women. And then they say, but only use it for 6 months. We'll talk about the risks in a second. So don't use testosterone for more than 6 months because it's not a testosterone deficiency. You should use an antidepressant because it's a SSRI deficiency. And what's interesting about that is SSRIs, antidepressants, and SNRIs, et cetera, most of them are associated with a reduced libido. So you're actually making the problem worse. And then psychotherapy, because of course it's a psychiatric diagnosis. Okay, so let's talk about the risks. So they talk about hirsutism, which is hair growth, and acne. So both of those things are a result of the conversion of testosterone to this thing called DHT, dihydrotestosterone. It is a more active compound that happens in the skin. So you have to get this conversion of testosterone and DHT in the skin, and it can cause hair growth and acne. That is something that is genetically driven for the most part. It's controversial anyway, but if a woman does have it and she is otherwise on a good dose of testosterone, it's something that's true in both men and women that can be mitigated with some potential either supplements or potentially even medications, but it's not that big of a problem. And then they talk about virilization, but man, not with the doses we're talking about. Could you actually cause physical changes to women if you give them high doses of testosterone? Sure, but we don't do that. And they talk about cardiovascular disease. Now, this is something that I've talked about a lot in men. And the truth is that there there was a 2023 study, a randomized control trial showing that there was no increase in cardiovascular events in high-risk men on testosterone. So this has not been studied in women. So I think they're just extrapolating those data, and this was put out before this 2023 study came out. So I think we can probably say that that's likely not true either. And then they talk about there is a relationship with breast cancer. Now, I like the way they say that because actually there is a relationship with breast cancer, but it's protective of breast cancer, does not increase the risk of breast cancer. That is shown in testosterone interventions in women over and over and over again. So they go on to say testosterone is not well understood as a sex hormone. Okay. So my question is, which part's not well understood? Is it not understood that testosterone is the dominant sex hormone in women at all stages of life? That women have 5 to 10 times more testosterone than any amount of estrogen of any form, of any breakdown molecule at any point in her life? So is it just not understood, or do people just not talk about it? Is it not understood that there is a relationship with testosterone and sexual desire? Because sexual desire in women has been ignored for decades, centuries, likely. And it's one of these things where I think testosterone got wrapped up into this social squashing of sexual desire in women, wanting to talk about it behind closed doors, but wanting to pretend it doesn't exist out in the open. And so because testosterone is going to potentially enhance women's drive, women's sex drive, women's strength, muscle in women, and potentially increase libido and desire, our society doesn't want to talk about that. They just want to pretend that it doesn't exist. And then if you don't have it, then call it a psychiatric disorder. So I am very, very against that. And I think that we should look to say, what does the evidence actually say about testosterone in women? Because it's not just about sex. It's not just about desire and libido. There are tremendous benefits for women, just like there are for men. Hey, sorry to interrupt this really interesting video on testosterone, but if you want to learn about how we put together a program to improve bone health and reverse osteoporosis, you should check out our free masterclass. If you're listening to this, you can go to drdouglucas.com. If you're watching this on YouTube, look in the description below for a link to that. All right, enough of this diatribe on me talking about testosterone. Let's talk about the actual research. So I just want to show you one study today. So this is a 2010, it was a prospective cohort study of 300 women. So this is not a randomized control trial. There's no control group. There are some weaknesses to this type of study. But what we can do with this type of study is to look at the impact of an intervention. And what I like about this study is they use a scale called the menopause rating scale. Now, I'm going to go through what is listed as symptoms of menopause on the menopause rating scale. But before I do that, I also want to point out that this study used not only postmenopausal women, but also premenopausal women. And I think this is a really, really interesting point because when you look at symptoms of testosterone deficiency, and we talk about how testosterone deficiency occurs, testosterone deficiency can occur before a woman goes through menopause. It can occur actually really early. I've seen women with no testosterone in their 30s and 20s, but it can occur much earlier than the loss of estrogen and progesterone because half of a woman's testosterone is made in her adrenal glands, the stress glands that make cortisol, epinephrine, and other stress hormones. So if you have excess stress, if you have adrenal dysfunction, then you're going to make less testosterone. That's why I see this very, very frequently in a specific population of women that are hard driving. These are women that typically are going to be either overwhelmed at home with kids, they're going to be both working and have kids, or they're going to be overwhelmed at work. These are just hard driving women that can either be professional or not. They just have high expectations of themselves. They're pushing themselves really hard and they push themselves into adrenal fatigue. When that happens, testosterone levels drop, and then they start to suffer from these symptoms of testosterone deficiency, which I'm going to show you in a second. So these symptoms of menopause, they start with vasomotor symptoms. So these are the things that everybody talks about with menopause, right? So this is hot flashes, night sweats, and sweating. These are likely more related to estrogen deficiency, although as I noted, men have them too, right? So there are symptoms in the AMS that men could potentially check off that get better with testosterone. Now, maybe that's because the testosterone in men also convert to estrogen. So perhaps there's a estrogen withdrawal syndrome there, but that's that. Then there's also heart symptoms, heart discomfort, heart palpitations, unusual sensations in the chest. Is that estrogen? Maybe. Then there's sleep problems, difficulty sleeping, insomnia, poor quality sleep. Is that estrogen? That's probably progesterone deficiency. And then there's psychological. These sound familiar. Depressed mood, feelings of sadness, lack of drive, mood swings, irritability, feelings of agitation, nervousness, overly sensitive, anxiety, inattention, feelings of panic. Does that sound anything like the list I told you about men with aging? Physical and mental exhaustion, general tiredness, decreased energy levels. Again, identical to aging in men. And then sexual problems, change in desire, decreased satisfaction, discomfort during intercourse rather than erectile dysfunction. And then there's bladder problems, and this is often associated with estrogen deficiency, urinary incontinence, increased frequency of urination, and vaginal dryness. Those are specifically going to get better with estrogen. And then it continues on. Joint and muscular discomfort, achiness, joint pain, muscular tension. Those are also identical to what we identified in the AMS for men. So other than the sexual differences, the actual anatomical differences, how similar are those two lists? Remarkably, right? And so again, as I mentioned with men, almost all of those things get better with testosterone. But yet when we talk about women and hormone replacement, the vast majority of providers are going to talk about estrogen and progesterone. Estrogen will improve some of those symptoms. Progesterone will improve some of those symptoms. But how effective is estrogen in improving all of those symptoms? Not. So how often do I hear this in our thousands of YouTube comments? I tried HRT, it didn't work for me. I tried HRT, I had bad side effects. I'm afraid to start HRT. The didn't work for me part is really frustrating because I want to know, whoa, all right, what were your symptoms? Do you know what your symptoms actually were? What were you trying to make feel better? What was the dose? Did you have enough, or was your doctor trying to give you just the smallest amount, which is really, really common? What was the route, right? Was it oral? Was it topical? Again, was it, topical progesterone instead of oral? There's so many variations out there. I want to know, man, what was the route? And then did they use testosterone or not? In the vast majority of these cases, they're going to have not tried testosterone. So again, I love this study because they included both the post-menopausal patients who have struggled, but then also pre-menopausal patients. So their intervention was testosterone pellets. So that's not how I like to do hormone therapy, and I don't recommend it. But it was an effective tool in this study because they were able to apply the same dose. Generally, with pellets, it's going to be a pretty high dose. And then they repeated the symptom questionnaire 3 months later. So that's enough time to go through that whole span. And this was the first time a lot of these women, I have to actually look and see, but it may have been the first time that a lot of these women had been exposed to hormone replacement. And if that's the case, there's usually an adjustment period where things continue to get better after the first exposure of 3 months. So anyway, the first 3 months, what they looked at is these 11 categories. And for both postmenopausal and for premenopausal, there was an average improvement of 60 to 74% in every single category. 100% of the categories, about 2/3 to 3/4 of an improvement per category. That's really remarkable for testosterone alone because you're not getting the benefits of progesterone. Arguably, they're going to convert some testosterone to estrogen, but that is testosterone alone. I think that is a really, really remarkable improvement. And so then let's talk a little bit about the premenopausal versus postmenopausal. So premenopausal women obviously still have estrogen cycling. They're still having periods. They still have estrogen. In the premenopausal women, what they noted is the psychosocial symptoms were more prominent. In the postmenopausal women, it was more of the hot flashes and the bladder and urinary tract symptoms, which would make sense, right? Because they lost estrogen. But both got better across the board, all of them. So one thing that was interesting here is that they chose not to repeat the test to see how much testosterone levels people had, which I disagree with. I like to test. But what's interesting is that they did test in the beginning. In the beginning, they found that women that were symptomatic, some of them had low testosterone, but not all of them. Some of them actually had upper third or upper quartile testosterone levels on labs. And so this is a big area of controversy where we find that some women can have symptoms of low testosterone with normal-ish levels of total testosterone or potentially even high levels of testosterone because it can be a receptor problem. It can be an issue with a binding globulin binding most of the testosterone and it not being available as free testosterone. So that's why you got to get the right labs. So I prefer to test. Obviously, in this study, they don't test their patients. They just treat by symptoms. My conclusion of viewing all this data, and I've looked at way more studies than this. I just wanted to present this one. But my conclusion here is that the Endocrine Society and ACOG says that there's no syndrome of testosterone deficiency. If you look it up, there is actually a syndrome called androgen deficiency syndrome in women. It exists. It's talked about in research papers, but obviously the Endocrine Society and ACOG don't recognize that. But my question is, do we actually need a separate condition? I think that there is a syndrome that is involving testosterone deficiency, and it's menopause. The challenge here, like I said, though, is that not all women are going to lose testosterone or all their testosterone as they age. If a woman has good functioning adrenal glands, then she could actually have reasonable levels of testosterone even through menopause. So not all women need testosterone, and this is where it gets dicey. So we have premenopausal women that need testosterone that have adequate estrogen, probably don't have adequate progesterone. And then we have postmenopausal women that don't need testosterone, but need estrogen and progesterone. So it takes somebody who can really peel apart the differences here and understand which are for which, and then treat appropriately. So then is testosterone the answer? Obviously not. I just said that some women don't need it. Is HRT going to fix all of these things for all women? No, because there's also a big component of lifestyle. This is why we build our program out the way that we do, where we talk about lifestyle out of the gate. We don't just replace hormones for women. We work on the lifestyle part too. We have to talk about the right nutrition. We have to talk about the right types of movement and activity and training. We have to get on board with the mindset and all the other foundational things that go along with a lifestyle that is going to support then optimized hormones. So it's a big picture thing, but we have to remember that perimenopause and menopausal women may be suffering from low testosterone, just like a lot of men in the same age range are, but men are more likely to be treated with it than women, and I think we're leaving a lot of women out. So all that said, please remember that you are created for greatness, so seek optimal, not average. Don't be afraid to be extraordinary, because you are, and that's what it takes. Couple of announcements. I mentioned the Masterclass earlier, so if you haven't done that, you should sign up for that. If you have done that and you're looking for more, consider our free Bone Foundations course. You can access all of these things from drdouglucas.com if you're listening, or if you're on YouTube, look in the description below for the links to the Bone Foundations course and the Healthspan Nation, which I discussed earlier. Have a good day. See you in the next video.
This presentation is for general informational purposes only, does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this presentation are at the user's own risk. The content in this presentation is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay obtaining medical advice for any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.